Another very interesting case there with some really important questions in respect of management and outcome and initially differential diagnosis. So saw this giant rhabdomyoma, these giant rhabdomyomas. I'm going to ask, actually, I'm going to ask Jan first, and then I'm going to go over to Laura. Jan, where we see rhabdomyomas, what proportion of these, I mean, we always think tuberous sclerosis first, don't we? But not all rhabdomyomas are tuberous sclerosis, are they? What
No,
proportion
so
do you think are
it is
where we see them antenatally?
it is a large majority, more than 90%. The theoretical problem is you say rhabdomyoma, but you don't know whether it's really rhabdomyoma or a fibroma or a teratoma or other cardiac tumors. It is almost always a rhabdomyoma, and the large majority is tuberous sclerosis. That's the easy way to look at it, but there are exceptions.
Okay, and Laura, you possibly see a slightly different population. Do you, in your referrals, is it 90%? I've assumed it
Yeah.
was slightly lower, about 60 or 70%, but
Yes, I usually quote 80% and above for risk of tuberous sclerosis.
yeah.
And in terms of differential diagnosis, as Jan said, there are different type of tumors, but usually when you see multiple tumors, intracardiac, it corresponds to rhabdomyoma. The main problem at the time of making a differential diagnosis is when you see only one tumor intracardiac, because it can be easily a fibroma depending on the location as well. Teratomas usually present towards the root of the great arteries, and they present with pericardial effusion, so it's a completely different clinical presentation. And again, most of the times it's a question about whether there are rhabdomyomas, multiple tumors. Usually that's the diagnosis with association with tuberous sclerosis. Single tumor most likely will be a fibroma.
Okay.
And the
So
prognosis is entirely different.
so when I see someone with rhabdomyoma, I'll immediately look very carefully at the baby's brain and the baby's kidneys, which I think is what Olivia did. And Olivia, I'm right in saying that the kidneys and the brain looked normal, didn't they?
Yes, they did. And I have to say the challenge was the minimal antenatal attendance. So there was hardly any follow-up. But certainly my assessment of the extracardiac anatomy didn't reveal any other lesions. She saw an obstetrician twice after that who also couldn't find anything. So the first report of any tumors in the brain was postnatal. Yes, but I just wanted to comment about the innocent, isolated cardiac echogenic focus, which we all reassure about, because I have had a case in a patient that was difficult to scan at 20 weeks while reassured, and that ended up being a rhabdomyoma or multiple rhabdomyomas and tuberous sclerosis. And now we are in the era where we are, I think, internationally trying to enforce a third trimester scan. So do you think we should be following up the innocent cardiac echogenic focus isolated if it looks a little bit prominent? Should we do a third trimester scan?
Wow, that's a big question. I'm going to hand that straight over to Laura. Well, I'm going to say no first of all, but
yeah, I'm gonna say no because I don't think we could have capacity to see all patients with an echogenic focus, and I guess probably that particular patient, maybe the focus was, as you said, more prominent than usual, or maybe the location wasn't the typical intracavitary of the single echogenic focus that we see normally. So it could be interesting to look at the case and see the pictures.
Yeah. So what you're saying is it's not likely to be just an echogenic focus. I mean, Olivia, did you see this woman with her? Did you scan her with the echogenic focus, or was
Yes,
it just a pinpoint echogenic focus?
It was an echogenic focus, and it apparently grew. The baby's doing very well, but I agree with Laura in that we'll be overloaded. But I think if everyone internationally has a third trimester fetal scan, we will pick up things that only arise in the third trimester. So
Yeah, I mean that's certainly true. I think we certainly I don't think none of us are giving the message that a pinpoint echogenic focus or two small foci would need follow-up. But what you're saying is that this was prominent and unusual, and in very rare cases you might see that. Interesting. There's a question here, an anonymous question: why was the CT angiogram deemed necessary? That was a postnatal, obviously, CT angiogram. Yeah, I would have thought it looked pretty obvious from all the imaging. So CT angio.
Yes, I think, well, firstly, that would be a good question for the very expert cardiologist who looked after this patient. But you know, the imaging, the cardiac anatomy was very distorted, and I think presumably this supported the decision making on the cardiac intensive care unit. This baby was delivered in a private hospital in Johannesburg with a very high level cardiac ICU and pediatric surgical facilities. So I'm sure it was with good reason that that this was done. You could see the very large PDA. I don't have the postnatal echo imaging video clips of the PDA and the displacement of the right ventricular outflow tract, but I think you can see quite a lot on the CT angiogram.
Okay, and there's a good question here. Is there any postnatal renal assessment for any AMLs, which I think is angiomyolipoma, isn't it? May have got that slightly wrong, but postnatal renal scan is absolutely essential in where there's diagnosis of TS. I'm sure you'd all agree with that. Okay.
Christoph, can I make another remark about the recurrence risk? Because as we all know, tuberous sclerosis is very treacherous conditions with very variable expression and sometimes minimal in one of the parents. So without a proper physical examination, or it would be much easier to just do a genetic test in both parents. Without doing that, you cannot be sure this is a de novo mutation. You can say it's probably likely, but it's all a bit subjective. And then even if it is a proven de novo mutation in the baby, the recurrence risk is, as we quoted, less than 5%. Which is not completely negligible, and parents will qualify for prenatal testing when they get pregnant again. So the recurrence risk is based on gonadal mosaicism, which is in tuberous sclerosis well reported. It's real, it does exist. So especially with parents who communicate difficult with the fetal medicine unit, I think you have to choose your words carefully and make some disclaimers. You know, without further investigations, we cannot be sure, because before they know they have a recurrence, and you will be the evil doctor that did not predict that.
Okay,
you know what I mean?
So Olivia is definitely not our evil doctor.
No,
Olivia,
no,
are you going to?
You have to be careful, I think.
I'm teasing. I'm teasing. So, are you with that information? I mean, the assumption you've made, which is very likely to be true, of course, is it's de novo. But do the parents know that it might not be?
Yes, I 100% agree and support everything Jan has said. I think, so first of all, this is where a referral to a clinical geneticist really helps. But where patients are financially or otherwise refusing to attend counseling with a clinical geneticist, it is left in the hands of a fetal specialist or even an obstetrician. And you're quite right, if you don't choose your words carefully, you can misguide and be the evil doctor. The challenge in this case prenatally is very little attendance. Culturally, when you are faced with a potentially difficult genetic diagnosis in certain parts of the world, since this is, you know, a forum across the board, there can be a little resistance to the acceptance that this might be something passed on. And prenatally, genetic testing for TS is not available in South Africa. It requires testing abroad at huge cost, but it is available postnatally, much cheaper. But when you talk about further investigation of the parents formally through blood testing, there can be some cultural resistance there. And then you're just left with a family history. And often they say, there's nothing in our family.
Yeah, I get that.
Yes. Yeah. No, that's, yeah, I think that for many joining this webinar, those will be extremely pertinent points, because you can't phone up, you know, it's not like being in London or, you know, Qatar, where you probably can phone someone, get them in and have a blood test the same day or the next day. It's a completely different story.